We would like to welcome everyone to the first CSRS webinar. Our topic today is central cord syndrome. We would like to thank the CSRS Education Committee for organizing this event. The chairs are Dr. Mesfin and Dr. Wright. This session will be led by myself, Elizabeth Yu, as well as Lee Tan, who is on. We will have a live discussion, but how the live discussion will work is that the attendees or participants will use the Q&A function in the Zoom to ask questions to the speakers. We will start off with presentations and then open it live for questions that the participants will place into the Q&A function, and we will bring those up as it goes along.
All right. Well, thanks, Elizabeth. I just want to take a brief moment to introduce our speakers and thank our speakers for doing the talks for us today. Our first speaker is Dr. Michael Fehlings, who really needs no introduction. He's a professor of neurosurgery at the University of Toronto, as well as the vice chair of the department. He has spent last few decades doing spinal cord injury research, and really is a thought leader in this area. We're very fortunate to have him to give us a talk today. And then after his talk, my colleague and friend Anthony DiGiorgio from UCSF will also give us some updated data from TRACK ICI and present some case examples in management of central cord syndrome backed with the latest data. Each talk is roughly about 20 minutes, and then we'll hold all the discussions at the end of both talks. Please use the chat box to submit your questions. You can submit your questions anytime during the talk as they come up, and Elizabeth and I will monitor the box and to facilitate the discussion. So without further ado, let's start Dr. Fehlings' talk.
Good evening. I'm Michael Fehlings, a professor of neurosurgery from the University of Toronto, and it's a pleasure to take part in this Cervical Spine Research Society sponsored webinar on acute central cord syndrome. And I'll be talking about some of the evolving concepts in management strategies. I have no disclosures that are of relevance to this talk, but I have founded a biotech company called Intelligex and have been a principal investigator on a number of clinical trials, and wish also to acknowledge different sources of funding. I'd like to acknowledge the co-chairs, Drs. Tan and Yu, and my distinguished colleague, Dr. DiGiorgio, with whom I'll be sharing the podium. This is essentially how I'm going to frame my talk. I'm going to present a few case vignettes to provide a perspective on some of the management challenges. I'll discuss changing perspectives on central cord injury and the evolving considerations on the role and timing of surgery. And I'll make reference to the importance of neurology and patient factors in guiding surgical decision-making. And I'll close with some take-home messages and some next steps. So here's a case of a 42-year-old woman I took care of. She's diabetic, and she essentially presented with a 6-month history of cervical myelopathy and was in fact scheduled to be reviewed by a neurologist when she had a fall with an extension injury of her neck. And as a result of critical injuries, was transferred to our unit. Her motor exam and sensory examination is shown on the right, and essentially she had a severe central cord picture with essentially a grade 0 function in the upper extremities and grade 2 function in the key myotomes in the lower extremities. She was hemodynamically stable. And so, how do we manage this kind of a patient? Here's the imaging. It's quite striking. She has quite a significant OPLL with a major degree of cord compression. Now, what if the case is different? And now I'm just playing with a few different factors here. So instead of 42, the patient is 82. In addition to diabetes, has coronary artery disease and is on a factor 10A inhibitor, but has a very different neurological picture. And instead of a severe Asia C tetraplegia, in fact, has more of a cervical myelopathy picture with mild hand weakness, gait imbalance, and remains ambulatory, and would be classified as an Asia D. And I think that these factors play a significant role in some of the decision making. So here are some of the key questions to consider: operative versus non-operative management, Asia C versus D, the age and the comorbidities, and then if we're going to undertake surgery, what's the timing? Should we do this, as with other forms of acute spinal cord injury, within 24 hours, or should this be delayed? Well, the epidemiology of acute spinal cord injury is clearly changing, as is referenced in this Lancet Neurology that we wrote a few years ago. And essentially, what we're seeing is that the overall incidence, despite prevention efforts, is remaining stable. But the types of injuries that we're seeing are different. We're seeing older patients with more fall mechanisms and more cervical injuries. And indeed, central cord injuries now become the predominant phenotype of spinal cord injury in North America and Western Europe. Central cord syndrome is clearly becoming a public health priority. Now let's make reference to Richard Schneider's classic description of central cord syndrome. This is a diagram from a medical artist showing some of the critical concepts related to this issue. So it's valid that this is a hyperextension mechanism in most people, and there's often pre-existing spinal stenosis. And phenotypically, patients present with a greater degree of weakness involving the upper and lower limbs. But there are a number of previously felt facts that in fact are no longer valid. And I'll make reference to a few of these. And indeed, new research is challenging this classic description of central cord syndrome. So firstly, the term itself involves a different pathophysiology than was proposed by Schneider. So the classical theory is shown here in this top diagram, where there's a central hematoma that picks off the medial fibers of the somatotopically organized corticospinal tract, and that this resulted in the greater weakness in the upper extremities than the lower extremities. But in fact, a number of lines of evidence, including Marchi degeneration and neuroanatomical tracer studies in humans and non-human primates, autopsy and MRI studies, as well as monkey transection experiments, have challenged this theory. And in fact, the contemporary evidence would favor that, in fact, central cord syndrome is a diffuse white matter injury, and that there is no somatotopic organization of the corticospinal tracts, but that about 90% of the axons in the corticospinal tracts subserve hand and upper extremity function. And this accounts for the discordant involvement of the upper extremities. And in fact, the clinical course of central cord syndrome mirrors that of other forms of incomplete cervical cord injury, as was shown in this classic article from the EMSCI study group out of Europe. And our recent data in over 600 patients with incomplete cervical cord injury have confirmed this. And here we've mapped out the trajectories of neurological recovery for a number of metrics, including upper and lower limb function, total motor scores, and sensory function. And here we've mapped out non-central cord syndrome and central cord syndrome. And really the trajectories almost entirely overlap. And it turns out that central cord syndrome accounts for less than 1% of the variance in the motor scores. So it's almost irrelevant. And the recovery after central cord syndrome is highly heterogeneous, as shown in this plot of the functional recovery of patients with an incomplete cervical cord injury due to the central cord syndrome phenotype. So there's strong impetus to revisit our treatment paradigms with regard to central cord syndrome, and is early surgery an option, in particular for the patients with more severe cord injuries, such as an AIS-C injury. There's a strong rationale to consider early surgery, and the concept here is based on a sound preclinical and clinical evidence. And the idea here is to try to mitigate the effects of secondary injury by targeting this with early surgical decompression. Now, the 24-hour cutoff is rather arbitrary. The concept here is that the timing of intervention is critically important. But the 24-hour cutoff was really framed on the basis of systematic reviews, surveys, and collating basic science and clinical studies. The Staskus trial was really the first prospective multi-center study to establish the importance of the role and timing of early surgical intervention. The median time in the early group was 14 hours, and the median time in the delayed group was 48 hours. And in this study, we found in over 300 patients with acute cervical cord injuries, the odds of seeing a 2 or more change in the ASIA impairment scale with surgery was much greater in patients who had early surgical intervention within 24 hours, and the odds ratio was almost threefold higher in the early group. Based on this line of evidence and a few other confirmatory studies, the first clinical practice guidelines emerged in 2017, suggesting that early surgery be offered as the preferred option in all adult acute spinal cord injury patients, regardless of level. And since that time, other evidence has further strengthened the support for early surgical intervention. And this is our study published last year in the Lancet Neurology in over 1,000 patients with acute spinal cord injury. And here we quantitatively found through a meta-analysis that there was a significant benefit with early surgical intervention for both cervical and thoracic cohorts. Here we see the impact on motor scores. Here we see the impact on shifting the odds of recovery on the ASIA impairment scale. And time to surgery can be modeled as a continuous variable. And importantly here, we see the changes in the ASIA motor score as a function of time, and the benefits are clustered to a significant extent within the first 24 to 36 hours. So what about central cord syndrome? And to address this question, we undertook this study, which was published last year in JAMA Surgery. The aims here were to evaluate the efficacy of early surgery within 24 hours in patients with central cord syndrome. And to undertake this, we used a big data approach, and we merged 3 large prospective multi-center data sets as shown in this slide. We examined the population of central cord syndrome, defined as a difference between the lower extremity motor scores and upper extremity motor scores of 5 or more points. And we specifically examined the intervention of surgical decompression. To address this, we used a technique called propensity-based matching, and we looked at the following covariates: age, mechanism of injury, the data source, the initial ASIA motor scores, the initial ASIA grade, and the initial neurological level of injury. So this was the total data set that we started with. And then after propensity-based matching, we had 93 patients in the early surgical group and 93 patients in the late surgical group. And these groups were beautifully matched on these covariates as shown here. And here are the raw data, and then graphically illustrating that we have a nice normal distribution of these data after the propensity-based matching. So I'll present the data in a couple of tables. So here are the overall data showing the motor and functional recovery at 1 year. And overall, we saw that there was a statistically significant impact on upper extremity motor scores for early surgical intervention. But the results vary depending on whether the patients are ASIA C or ASIA D. And the most striking effects are seen in the ASIA grade C patients, where we saw statistically significant impact. And this impact was less apparent in the Asia grade D patients, largely because of ceiling effect issues that we see with this form of neurological scoring. So coming back to our case, again, this 42-year-old woman with an Asia C cervical cord injury with this a severe degree of cord compression from OPLL. So how do we manage her? Well, interestingly, we actually enrolled her in the RISCUS clinical trial where we were studying the effects of the sodium glutamate antagonist riluzole. And this should be of interest as this provides evidence that we would treat these patients similar to other forms of a cervical cord injury. We can perhaps discuss this in a few minutes. And how do we manage this patient? Well, the patient was taken to surgery within 12 hours of injury, and we undertook the following procedure: a posterior decompression infusion from C2 to T2. This is the X-rays of the implants that were placed, and this shows a very effective decompression of the cervical and upper thoracic cord. She was discharged to rehab within a week as a C4 Asia D. So she'd actually made fairly significant rapid recovery. And gratifyingly, she was actually in Asia E at 6-month follow-up. So take-home messages here. Central cord syndrome should be treated as any other form of incomplete cervical cord injury. We need to consider the severity of the injury, Asia C versus Asia D. Asia C central cord injury is benefited by early surgery, provided the patient is medically stable. Asia D central cord injury is benefited by surgery, though the impact of early surgical intervention is less clear. And we need to consider patient factors, younger versus older patients, medical comorbidities. And decisions around the role and timing of surgery need to be factored around the neurological deficit, the imaging findings, and the patient factors. So next steps. The guidelines that I made reference to in 2017 are now being updated. This is an effort sponsored by AO Spine and Praxis. These updated guidelines are expected later in 2023, and these will strengthen the recommendations on the timing of surgery for acute spinal cord injury because of the wealth of studies that have been published since 2017 supporting this concept. And the issue of the Asia D central cord injury remains a knowledge gap, and to address this, AO Spine has sponsored the INTWIN study that is anticipated to start in 2023, and the principal investigator is Jeff Wilson out of Toronto. And on that note, I'll close and look forward to Dr. DiGiorgio's talk and the subsequent discussion.
Hi, my name is Anthony DiGiorgio. I'm an assistant professor at UC San Francisco, and I'm going to be talking about some of our experience with central cord syndrome, as well as our track spinal cord injury prospective research project and how we've used some of the data from Track SCI to help treat not only central cord syndrome, but all cervical spinal cord injury and all spinal cord injury in general. Here are some of my disclosures. I don't think any of them are relevant for our talk today. And my objectives are to discuss some of the controversies and literature surrounding central cord syndrome. So first, I want to talk about our multi-center research collaborative, Track Spinal Cord Injury. So transforming research and clinical knowledge in spinal cord injury. This was started by a couple of our basic scientists, Jackie Bresnahan and Mike Beatty, who have expanded it to a broad clinical multidisciplinary team that includes members of the departments of orthopedic surgery, neurosurgery, neurology, anesthesia, PM&R, radiology, and emergency medicine, as well as a host of data scientists, clinical research coordinators, and patient advocates. So really multiple different perspectives in this project to help us track spinal cord injury in a prospective manner. Originally, this was out of San Francisco, so the bulk majority of our early patients are out of San Francisco, but we have since expanded it to multiple sites. We have over 200 enrollments. We have some of our early data published here. And you can see here the sites that are currently either onboarding or enrolling patients into the project as we speak. And so because this is a prospective, we're really just tracking the different practices of care across the country. And we want to see how these influence outcomes at 1 to 2 years, not only for things like the INSCI score and motor scores, but for a variety of things such as quality of life scores, psychiatric health, etc. So it's been a very fruitful project, and I'll show how some of our early data has been used to help guide our treatment decisions in central cord injury and spinal cord injury in general. I think this is a pretty common case. We've all seen this case before. Older gentleman falls, has a low velocity accident, trauma, and comes in with pre-existing cervical stenosis and clear symptoms that match the classic central cord patient, right? The arms are weaker than the legs, the cape-like distribution of paresthesias. And then when you get an MRI, it shows this pre-existing cervical stenosis with an acute injury superimposed on it. I think we've all seen this patient numerous times. I don't think there's any controversy on whether or not you need an MRI or that this patient does eventually need a surgical decompression. I think one of the useful things that we found out of our track SCI data is the MRI not only is useful for treatment, but it gives very good information for prognosis. We were able to develop something called the basic score, which is able to look at the cross-sectional injury area and give an idea of how well the patient may recover, what their chances are, even at discharge, based on what the basic score shows on the MRI. So the basic score goes from 0, which has no cord signal abnormality, all the way to 4, which shows evidence of spinal cord hemorrhage. And we can see here the patients that come in, even if they're in Asia A at presentation, if they're a basic 2 or basic 3, they have a significant chance of improvement by the time they, discharge from the hospital. Whereas a basic 4, if it shows cord hemorrhage, gives them much less chance of improvement at discharge. Taking this a step further, we're actually able to show that the volume of spinal cord injury is even a greater predictive value than the basic score when it comes to lower extremity motor score. So we're able to use a computer algorithm to calculate volume of injury throughout the site of compression, and that volume of injury at discharge has a much better predictive value than the basic score. You can see the basic score on the left there, and the volume injury on the right has much better predictive in the lower extremity motor score by discharge. So these are a few ways that we can use the MRI to not only show us what levels need surgery, but how these patients have a chance of recovery just by discharge. Really helps with family conversations, being able to have that prognosis. So one of the big controversies, I think, about central cord syndrome is it safe to operate in an early fashion, in an acute fashion on some of these patients? So one of the things we pulled from our early track SCI data is matching central cord patients with non-central cord, typical your classic cervical spinal cord injury patients. Our institution tends to operate on these patients in an emergency fashion in both cases, both for central cord and non-central cord spinal cord injury. Our institutional goal is within 12 hours of injury to get the patients to the operating room and to get them decompressed. And so our early data, we pulled and matched a group of central cord and non-central cord patients just to show that operating on these patients in an early manner is indeed safe. One of the things that the old teaching was that for central cord patients, it's not safe to operate on them soon. They're often older patients. Taking them straight to the OR is an undue stress, and that you should let these patients plateau and let their exam improve on its own. And once it's plateaued, take them to the operating room. So we've shifted away from that. And I think some of our early data does show that this is, in fact, safe. There's no increased hospital length of stay. There's no increased ICU length of stay. There's no worse outcomes acutely for patients who undergo early surgery for central cord syndrome when compared to patients with normal cervical spinal cord injury. And furthermore, when we took the difference out to 6 and 12 months using the spinal cord independence measure, we found that there were no functional differences on these patients for their spinal cord independence measures at both 6 and 12 months. Furthermore, and I'm sure Dr. Fehlings has talked about this in his talk, but when you look at the functional outcomes in patients who are operated on early versus late for central cord syndrome, there is actually a statistically significant improvement in the lower extremity motor score on patients who are operated in an early fashion. What he defines is earlier than 24 hours. So I think this, combined with our data on safety, really does show that these central cord patients should be operated on in an acute fashion. Furthermore, should we even be calling it central cord syndrome? Some of the pathologic data that's coming out is showing that there's not as much of a somatotopic organization in the cortical spinal tract as we had originally thought. that actually the hand function is more located in the lateral cortical spinal tract, whereas the medial cortical spinal tract has more to do with locomotion. So it isn't actually affecting the center of the cord as much as the prior conventional teaching had thought. So one of the things that we've started calling it is just spinal cord injury without instability. And that since we treat these patients the same, that the central cord syndrome is really just on the spectrum of spinal cord injury. It just happens that these patients have an acute or chronic spinal cord injury and they don't have an instability, but it's not a distinct pathologic mechanism as much as it had previously taught, and therefore should be treated the same. And going with that, the AO spine, and I'm sure Dr. Fehlings has mentioned this in his talk as well, but they've issued a practice recommendation that decompressive surgery in central cord patients be performed within 24 hours of their injury. And again, our institutional benchmark is 12 hours. This is largely dependent on the resources of your institution. A lot of institutions can't do this in the middle of the night. It's unrealistic from a resource utilization. But I think it's something that we should try shifting to over time as we make these cases more and more evidence that these cases should be handled in an acute fashion. That brings us to the broader question of the timing of surgery of spinal cord injury. I think there's ample data, and again, Dr. Fehlings has done a good job in aggregating a lot of this data, showing that early surgery really does give patients a better chance of recovery after spinal cord injury. This is 1 year after follow-up. Patients with early surgery compared to late surgery, as defined as 24 hours after injury. Early surgery shows a statistically significant chance of improvement in motor score, in Asia motor score, at 1 year after their injury. I think this data is pretty clear, and I think a lot of trauma institutions are now shifting towards treating spinal cord injury as an acute injury, taking these patients in the middle of the night, even if they're Asia A, to give them the best chance of recovery as possible. Taking this a step further, I said our institutional benchmark was 12 hours, and a lot of it is because of this ultra early surgery data that we showed that not only is early surgery better than late surgery, but ultra early surgery gives a dose response, showing that the earlier you can take patients to surgery, the better chance they have, even at discharge, of improving their Asia grade. I think our data is pretty convincing. And we've certainly stood by this, and we try to take all these patients within 12 hours of their injury to get them decompressed. And a lot of this revolves around the basics of spinal cord injury, spine trauma care. We can't do anything to prevent the primary injury that's occurred to the patient's spinal cord. So everything we do revolves around preventing secondary injury. And that starts from the moment the patient hits the trauma bay. We like to be there, making sure that their neurocardiogenic shock is managed appropriately, that any respiratory failure is identified and managed appropriately. If the spinal cord is not getting perfused, and if the spinal cord is not getting perfused with richly oxygenated blood, then that increases the chance that the patient will have further secondary injury after their primary injury. We again feel that early decompression and stabilization helps these patients have a better recovery. Early decompression, again, shown by our dose response, that the quicker you can get the spinal cord decompressed, you can more quickly restore normal hemodynamics and allow limiting of that secondary injury. And stabilizing these patients early on helps them get turned in the bed, helps them every time that they're shifted or moved in the bed, they're not creating more micro trauma to the spinal cord if it's being actively compressed and it's unstable. Putting a patient in a cervical collar simply doesn't provide the same stabilization that surgical fixation does. So once you've stabilized the patient, no longer when the nurses need to turn them or shift them in bed are you creating worse injury to the spinal cord. So early decompression and stabilization helps decrease the rate of secondary injury. And the supportive care, having the patient in the spinal cord or in the intensive care unit with specialized spinal cord injury teams, physical therapy, respiratory therapy, nursing, et cetera, and focusing on things to maintain spinal cord perfusion. Again, managing their shock, managing their blood pressure, managing their respiratory status, managing all the complications that come up with spinal cord injury, such as increased DVTs, bladder infections, bed sores, psychiatric illnesses, et cetera. All these need to be handled in a specialized intensive care unit. We've actually instituted a code SCI or an SCI activation at our institution. This can be activated by any patient that presents with traumatic tetra or paraplegia, and can be activated by the trauma teams or the emergency doctors, as long as there's no chronic or confounding cause. This is one order set within our electronic health record that activates multiple teams, such as the intensive care unit, the spinal cord injury unit, the spine surgery unit, and the radiologist, to make sure that we can get these patients immediately from the trauma bay to the MRI, and from the MRI to the operating room. It also institutes a number of patient care pathways, such as the insertion of an arterial line and maintenance of mean arterial pressures, the insertion of a Foley catheter. The patients need, if they're going straight from the trauma bay to the MRI, they need to have extended length IV tubing attached. They need to have MRI compatible EKG leads. And they need to have all the appropriate transport mechanisms in place to get these patients to the MRI scanner and then to the operating room. This one order set activates all that. So all these things are happening in parallel. They're not waiting for the neurosurgery resident to come down and evaluate the patient before these things start happening. It all happens in parallel, and has really allowed us to cut down on the amount of time it takes for us to get a patient from the trauma bay to the operating room for an emergency decompression. And again, this allows us more effective prevention of secondary injury. We speak about spinal cord perfusion. A lot of the data has come out showing that a higher perfusion pressure helps reduce the amount of secondary injury and increases the chances that patients will have meaningful recovery in their motor scores after their injury. So this is some of the data that came out even prior to our TRACK SCI collaboration, showing that patients with mean arterial values that are elevated in the first 7 days following their injury have a much better chance of having an improvement in their AIS by the time they're discharged, even when we include the patients who are ASIA A. And of course, this has led to a practice guideline from the AANS-CNS that recommends maintaining the blood pressure at 85 to 90 for the first 7 days after acute spinal cord injury. Some of our data we've looked at using machine learning techniques, because we have really granular data on a minute-by-minute basis as these patients are getting treated. So Abel Torres Espin, one of our wonderful data scientists, was able to break this data down. And using machine learning algorithms, he found that the amount of time outside of this mean arterial pressure range actually was one of the biggest predictors of a patient failing to have a improvement in their motor score by time of discharge. And he was actually able to create these RUC curves to show the predictive ability of time outside this mean arterial pressure range, and seeing whether or not a patient would be ASIA A at discharge or ASIA D. Taking that a step further, Nitin Agarwal and then med student, now intern Alexander Abedi, were able to use a decision tree based knowing analysis of our intraoperative mean arterial pressure data to see what was the best predictor of improvement in spinal cord injury motor score at time of discharge. And more than the basic score that I showed earlier, more than the age of the patient, more than their ICU length of stay and length of surgery, the one thing that had the greatest predictive ability of whether or not the patient would have an improvement in their motor score was the time outside of this Goldilocks range of mean arterial pressure that we defined as 76 to 104. We're able to take that a step further and show that there was an actual cutoff of 93 minutes. So if a patient spent more than 93 minutes outside of this Goldilocks zone, it significantly decreased their chance of having an improvement in their ASIA score by time of discharge. Also showed that the pressor of choice mattered, that using dopamine had a lot higher rate of complications than using phenylephrine. And speaking of pressors, these are often patients who are elderly. Spinal cord injury tends to happen in the very young and very old, and central cord syndrome specifically tends to happen in patients who are a bit older. This is again some of our data out of TRACK, looking at our elderly patient population, patients over the age of 65, and showed that the use of vasopressors, even norepinephrine, had a significant higher rate of complications, specific cardiovascular complications with spinal cord injury. The outcomes on these elderly patients are not great. They have a very high complication rate to begin with. And again, some of our data showed that using pressors in these patients increase their complication rate even further. So while there is that recommendation of keeping the mean arterial pressure up, while we still have shown pretty convincing data that time outside of that Goldilocks zone of arterial pressure can improve your outcomes, we need to be judicious about this and not just bump everyone's pressure up blindly without considering whether or not the patient's older and what their cardiovascular status at baseline might be. So that's why in a lot of these patients, we've moved away from just using blanket mean arterial pressure to using spinal cord perfusion pressure. Some of this data has come out of Brian Kwan's group in Vancouver. And the early study was called Camper, where they just measured spinal cord perfusion pressure by inserting a lumbar drain into the lumbar cistern and subtracting the mean arterial pressure to give you your spinal cord perfusion pressure, showing that this changed significantly after decompression. And that, again, like the mean arterial pressure, there was a Goldilocks zone where patients had a significantly higher chance of improvement if their spinal cord perfusion pressure was maintained in a certain range. So we've managed to shift this. This is now our practice of care at our institution, where every patient with spinal cord injury with an ASIA grade of C or worse receives a lumbar drain and has their spinal cord perfusion pressure managed rather than their mean arterial pressure. We'll use a cutoff of 65, and this diagram here just shows how we'll level the intrathecal pressure manometer at the phlebostatic axis, which we define as the fourth intercostal space in the axilla. So this allows us to hopefully cut back on our pressor usage and manage this not only by increasing the mean arterial pressure, but by decreasing the intrathecal pressure by draining CSF. Hopefully, therefore, reducing our pressor usage, especially in these older patients who tend to have more complications from pressor use. Looking at this further, some of the data out of London from Marios Papadopoulos' group shows that if you measure the intraspinal pressure, which he did by placing a probe at the site of injury, a subdural probe at the site of injury, and comparing it to the CSF pressure in the lumbar cistern, there's often some discordance between these two. However, there's also a good amount of concordance. And so one of the theories is that if the spinal cord swells and you lose patency of your subarachnoid space, in that case, the intrathecal pressure measured at the lumbar cistern will be significantly lower than the intraspinal pressure measured at the site of injury. However, as long as you maintain a patent subarachnoid space, the two pressures are concordant. And you can see these in this the bottom line here in figure B, where the red and blue lines tend to line up. We believe that's where the intrathecal subarachnoid space is patent. And then the top figure where the ISP and CSF pressure are discordant is because the subarachnoid space is no longer patent. And so the lumbar cistern is no longer reflective of the site of injury. In central cord patients, often we find that the subarachnoid space remains patent when we get postoperative imaging because there is a acute on chronic component to the injury. These are patients who have a chronic spinal cord compression and spinal cord stenosis. They tend to have a more withered spinal cord. And so after the injury, it's not as much of a high velocity injury. So there's not as much swelling. Their cord is shrunken to begin with. And so we really do see that we're maintaining the intrathecal subarachnoid space. And so we're not as worried about the ITP being an inaccurate reflection of the intraspinal pressure in our central cord patients. So again, I think that's another reason to consider spinal cord perfusion pressure in central cord patients, because it gives you a lot better chance to manage it via CSF drainage and hopefully reduce the pressor use in this patient population who's already older at baseline and more susceptible to complications from vasopressor use. So some final thoughts. Central cord syndrome really should be treated urgently. We should take these patients, hopefully, if they're hemodynamically stable, from the trauma bay to the operating room to give them the best chance of having improvement in their neurosurgical, in their motor scores and their ASIA scores by the time they are discharged, and giving them a best chance of recovery. In these patients that are older, we need to have judicious use of pressors, and we really should consider using spinal cord perfusion pressure to help guide the treatment. And then I think still to be determined, is central cord syndrome a separate entity, or is it along the spectrum of acute spinal cord injury and should be treated equivalently to that? So thank you so much for your attention today. And here's my contact information if you have any questions.
All right. Well, that was great talks from both Dr. Fehlings and Dr. DiGiorgio. I think we have a few questions in the question box, and if anyone have questions, please feel free to type it in, and then Dr. Yu and I will moderate. So Dr. Fehlings and Anthony, there's a question from one of our attendees. Is Dr. Tim Chrysikis. He is asking that the central cord syndrome prevalence of it has been increasing with the aging population, and more and more people have increasingly degenerative spine, including sometimes deformity. And when you encounter a patient with concurrent deformity and spinal cord injury, how do you guys plan for the surgery, and what are the considerations you take in those sort of circumstances? Maybe Dr. Fehlings can chime in first, and then Anthony can follow.
Yeah, it's a great question. So most of these patients have degenerative cervical myelopathy, which has either been untreated or unrecognized and then sustained an extension injury. And so, often the surgical options are similar to what one would use in DCM. In most cases, a cervical laminectomy and a lateral mass fusion, as I showed in the example case, is sort of the bread and butter technique. But then you need to individualize the treatment. Sometimes there is instability, so you need to take that into consideration. And then sometimes, there'll be a focal anterior compressive pathology that you may, wish to treat anteriorly. It would be pretty uncommon to do a combined front back procedure, but that might be an option if there was, a significant deformity present that you might need to, to deal with. But in general, in these patients that might be somewhat fragile, you want to do an effective decompression and try to do this through a single stage procedure if possible.
Yeah, I totally agree with Dr. Fehlings. These patients are coming in extremis, and the most important thing is to get them decompressed as quickly as possible. And so I think if you're going to try to correct a deformity in an urgent case in a properly elderly patient, you're probably doing a little bit too much, and I think maybe putting them at risk. Somebody who has like a severe kyphotic deformity, I always ultrasound after I decompress every time to make sure that the cord drifts back and that you do achieve an adequate decompression. There have been a couple of times when I've seen residual anterior compression and then turn the patient over as long as they're stable and gone after an anterior osteophyte or disc or something. But the vast majority of the time, you're taking patients in extremis, maybe in the middle of the night, to try to get them decompressed. So that's no time to be doing a big deformity correction at the same time. You can always go back and do that later if it's really needed.
These have been great talks. If people have more questions, please put them in the question and answer box. I have a question. Dr. DiGiorgio, your setup at UCSF is great with the, measuring of the pressures of the spinal cord, as well as getting patients, to the operating room so quickly within less than 12 hours, as well as, treating with the spinal cord injury. This question is both for Dr. Fehlings and Dr. DiGiorgio. Does it make a difference in terms of how quickly you take them to the OR with AIS of A, B, C, or D? I know Dr. Fehlings had commented there's a difference with C and D, but would it change your management with A's and B's?
You want to go first, Anthony?
Yeah, sure. So it doesn't change my management with A's and B's. I think patients come in, and what's the difference between A and B and even a C is usually the exam by some intern, possibly off service. And not that we don't have great interns, and I don't trust them, but I tend to treat everyone the same. And furthermore, it's that is the fact that they're lying there unstable, and that they're getting continued microtrauma, and that the nurses are going to be turning them for keeping them clean. The bed's going to be moving and rolling, and all that little microtrauma is going to continue to just make the situation worse. And even in Asia A's, I think we're seeing pretty good evidence that they have a 30 to 40% chance of improvement even by discharge. And so the real question is, how many are those are actually Asia A's, or are we seeing a true ability of these patients to get better? So we treat them all as if they have a substantial chance of improvement and go immediately.
Yeah, so I mean, I would concur with those, comments. So, the Asia A patients are an important consideration because, the old way of thinking was that, well, the injury is complete, it doesn't really matter. And that thinking is not correct. So about 40% of patients who are Asia A in the initial examination period, in, say, the first 24 hours, will convert, particularly if they undergo early surgical intervention. So that's a fairly substantial number. And then Valerie Terwengel from the Netherlands showed in a J Neurotrauma article that even when patients don't convert, they're Asia grade and they remain Asia A, they recover more motor levels. And so, even if someone remains in Asia A, if they're a C7 or a C8 versus a C5, that has very substantial functional impact for the patient. And so you're often fighting to try to get as much back as you can. And so I would say that one should treat the Asia A cervical patients in an acute fashion when possible. I think one of the challenges that we're running into is that we're dealing increasingly with an older patient population with many medical comorbidities. And for me, that represents a substantial challenge. I don't think there's really much controversy anymore in terms of the idea of time as spine, and that it's a time critical event and that early decompression benefits the outcome. I think it's very clear. The challenge, though, is when you have an infirm older patient with multiple medical comorbidities, how do you balance that? And so that's sometimes where some real challenges occur. And what I would say is that if one needs to delay intervention in those patients, that even delaying the surgery by a few days will still benefit the patient. And so I think that there's a lot of judgment that needs to be required in these older patients. And I think this is one of the issues that does arise in the discussion of central cord syndrome.
Great.
Great comments. I think we have a few more questions. One of them is to Anthony from Dr. Dubs, our current CSRS president, so no pressure. So question for you, Anthony, is that considering a lot of these patients are older and sick, are there complications when you do the intrathecal monitoring? Do you see infections, etc.? Some patients may have concurrent TBI. Are there any sort of concerns about draining CSF from the lumbar spine causing herniation or things like that? Have you seen any complications? How is it handled?
Lee, you say no pressure, but following Dr. Fehlings in a pre-recorded talk is probably one of the most humbling things I've done. So yeah, definitely no pressure. I think the risks of intrathecal monitoring are a little overblown. I've seen one complication, and that was a retained catheter fragment in probably a couple hundred patients. I've never seen an infection from it. Our nurses are excellent because we do so many of them. The nurses are really good with sterile procedure, and they're really used to doing these, to taking care of these lumbar drains. We don't aggressively drain. We have a cutoff. We've used the LiquiGuard device a couple times in some cases, but the nurses are excellent and very comfortable with these lumbar drains. We don't drain if there's a TBI. Obviously, we're not going to be draining if there's any risk of cerebral herniation. And then the infection risk, I have never seen an infection from one of these. And the DVT risk, I think, is largely overblown as well. There's a lot of worry about giving enoxaparin with the lumbar drain floating around, but our protocol is starting enoxaparin on post-op day 1, and I haven't seen a complication from bleeding from one of these lumbar drains. But I think the real key is just getting your nurses used to it, because they are another device that they have to know how to manage, and having a nursing staff that's comfortable with them is important.
Great.
So we had a couple questions about steroids. How about could we have some comments from both speakers?
Yeah, I'm actually debating this topic on Monday at the AANS. I was astonished that this topic continues to raise its ugly head. So the 2017 guidelines from AO Spine essentially indicated that it's an option to use steroids. So the pendulum kind of went one way and then it went the other way, and it's sort of now kind of in the middle. And so I think as neurosurgeons and as spine surgeons, we use corticosteroids a lot, and I think we're pretty good at balancing the benefits and versus the risks and the side effects. So I think we're pretty aware of this. So I think in younger patients with a cervical injury, what the heck, it's worth a shot to try it. The older patients, you need to then judge. So if you have a patient who's diabetic, you may wish not to use this, and somebody's got a very severe thoracic injury, maybe not. Younger patients, cervical injuries, I'll use it, recognizing that you need to always kind of use judgment in terms of assessing it. But it's a valid option, and I would say that the bottom line is that the judgment should be left in the hands of the treating physician. And so I think. But it's and sometimes the issue arises also medical legal. I think that issue is really not so much of an issue anymore, but it is important, I think, to document your decision making. And I think either way, if you've documented it, then you could justify it, because it's really, there's sort of equipoise, right? It's sort of one way or another way. As long as you you justify it, I think you can it would be a rational decision.
Anthony, what do you do in your practice?
Yeah, I totally agree. In a central cord patient, elderly person, not at all, absolutely not. But if someone comes in young, healthy, that has a very low risk of infection or wound breakdown, then yeah, I think steroids are appropriate. I agree totally with Dr. Fehlings, documenting it. And I will actually, if I'm going to give steroids in a young person, I'll get a consent for steroids, just because there is that AANS CNS guideline that discourages its use. So, but I totally agree. I think that there is a place for it, and we should be given it as an option.
Great. And one, more practical comment or question from our audience from Dr. Mohammed Maki. It seems like the more and more literature is suggesting earlier surgery is better for the spinal cord injury patients, and 12, 24 hours. But if, logistically speaking, if someone comes in the middle of the night and, sometimes the hospital staff is not the normal, spine staff, they don't even know what the instruments you use. So how do you balance going, between in the middle of the night at 2 a.m. versus wait until 7 a.m. when your normal crew comes in? How do you guys deal with that?
Well, logistics are important. I want to applaud what they're doing at UCSF with regard to the TRACK SCI program, and I think it's going to be the way to go. It takes a lot of logistical organization, to do this. And I'm on a mission to get organized medicine to support the concept that spinal cord injury is a medical emergency, needs to be handled urgently, because a lot of places are not like UCSF in Toronto, where this is dealt with as a medical emergency. A lot of places are, well, it's really unfortunate, but it's not that time critical, right? And the reality is that even in North America, there's a lot more variance than I would like to see. So I'll be very happy if I can see that the majority of patients are given the opportunity for early surgical intervention. And the other thing I point out in the lecture is that the 24-hour cutoff, it's arbitrary, right? Like it's a time-dependent event. And I don't want to give the sense that, oh, well, you can just sort of delay things and it's okay. You really should try to go in as early as possible. And then you need to consider the logistics and the safety. And so, it takes a lot of organization and setup to do that. And so you need to factor this into consideration. And it takes a lot of organization and dedication to kind of set it up. And Anthony, I think you should comment because of the setup that you guys have set up at UCSF, which I think is quite remarkable.
Yeah, you have to have the infrastructure in place to do this effectively, right? One of the great things about TRAC is that we have buy-in. There's ER and anesthesia in the TRAC project, so there's total institutional buy-in, which is completely necessary for this. You make excellent points that if you're doing this case at 4 a.m. with the backup scrub tech who doesn't even know what a pedicle screw is, you may not be doing it safely. And if you're doing it and you're dead tired because you've been up all day, doing spinal deformity surgery, that may not be in the patient's best interest. So you really do need an institutional buy-in. And this kind of goes into a lot of my socioeconomic and policy research, is that you really need almost a shift in how you treat neurotrauma, right? I think the neurotraumatologist model makes sense if you're doing these cases in the middle of the night. Trying to balance this with a busy elective practice, that you're just going to burn yourself out. If you're at a busy trauma center, you're taking spinal cord injury in the middle of the night, and you have an elective practice on top of that, it's just not feasible, right? So you really need that infrastructure there. Orthopedic surgery, general surgery has realized that it pays to offload trauma onto dedicated trauma specialists in those situations, right? So the person who's doing elective gallbladders isn't taking the trauma call in the middle of the night. And so I think neurosurgery sort of needs to have this institutional shift. And that's the way we're able to do it at UCSF. Is I don't do a lot of elective cases when I'm on trauma call. My operative volume comes through the ER for those weeks that I'm on call, and I do my elective stuff on other weeks when I'm not covering the trauma center. So you really need institutional buy-in, and you really need to almost adapt a traumatologist workflow in order to be able to do these effectively and not burn yourself out. Because I can't be doing a full day of elective spine, after I've been up all night doing an SCI case. It's not feasible. So you need that infrastructure there. You need institutional buy-in.
Great. Okay, I think that is time. We're right on time. There are some additional questions. Perhaps we can share Anthony's and Dr. Fehlings' email or my email. You can write to us, and we're happy to answer your questions. So again, I want to thank Dr. Fehlings, especially on East Time Standard Time, very late in his region. And also the CSRS committee for putting this on. And there's many additional sessions to come in the future. So, and thank all the attendees for attending and sharing this learning experience with us. Okay.
Thank you very much. It's been a pleasure.
Thank you.
Enjoyed it. Thank you very much to all of you and to CSRS.
Okay.
Right.
Thank you. Take care. Okay. Bye-bye.
Good night, everyone.